So what we're going to do is talk about what are the new rules. In 2021, starting January, all the rules changed for our documentation, and so how are they going to impact us? How are they going to go going forward? All right, so here, current rules and impact, E&M understanding. We're going to talk about the inpatient stuff as well as the outpatient, because if you still do inpatient documentation, the old rules still apply, okay? So everything you're used to, all the stuff that has been going on for the last 26, 28 years with the 95, 97 rules, okay? Inpatient side, ER, those rules still apply. The outpatient stuff is what really has changed for us. And that's going to make a big difference because going forward, we're basically, as you see this little guy right there, we're taking this leap, all right? We're jumping off into this new deep water, not knowing what to expect. And as you can imagine, his sensation with the arms flailed out there when he first takes that jump, yes, it's a little scary. But once you hit the water and you realize, wow, the water's nice and warm, it's fun, you know, this is easy. We can swim in this, we can go up and we can jump again, right? Because it's a good time. That also is my 5-year-old, by the way, right? So here, the history, physical exam, medical decision making, these things still stay the same in the new rules, but the history and physical exam no longer count for your final diagnosis coding, okay? So, the bad habit, and you'll see this in a slide coming up, the bad habit of clicking a bunch of boxes for ALTA goes away. Now, I have not heard that ALTA is going to be updated to adjust to these new rules, because ALTA is binary, it's a software, it's looking for click boxes to calculate stuff, which is why it'll get the physical exam close if you click a bunch of boxes, but it never gets our medical decision making right because it can't tell us based on what we write if a problem is worsening, stable, unstable, things like that. So it's imperative that we as physicians and providers understand the new rules because it's going to impact how we choose the code, right? Now, again, it's about how we document, how we describe things. And what do you do, sir?
Internal medicine, and I work in the Warrior Clinic.
Perfect. All right. So internal medicine. So my wife's also internal medicine. Probably one of the only urologists who've read all the MCSAPs. I know exactly what you do. All right. But the thing is that when he writes his note and he sends the patient to me, you know, for a referral, maybe it's for hematuria or nephrolithiasis or something like that. I can pick up that note and look at it and say, I know exactly what's going on with that patient. The challenge that I offer to you is that if you can write the note the way you would want the note written for your mother, your father, your brother, your sister, so if they saw somebody else, they'd be able to pick it up and you knew your family member was going to be taken care of, that's what we need to do. Because again, we're just telling the story and we're going to use these elements to tell the story. Now, on the inpatient side, these rules, these are the old rules, they still apply. So for HPI, location, duration, quality, what are those factors? It's kind of the stuff to say, hey, what's the lead up in the story, right? Then here, you always want to make sure for new patients and new consults that you always have all three: family, social, past medical, surgical history. If you don't have one of those in there, you actually could lose credit on your inpatient consult. So much so, because I saw how you looked there, it can knock you down from a level 3 back down to a level 1 if you didn't have all three of the history components. The same way, the most common reason we don't get a new patient level 3 is because we failed to get the 10-point review of systems. In GME settings, hands down, we had this at Eisenhower, this is what we saw the most, that the hospital admits never went past level 1 because the residents didn't give us a 10-point review of systems. By far the most common reason we had that. It's like a $115 difference between the 1 and the 3, okay? It makes a difference. That's extra productivity that the hospital wants to see, that the commander has to go and describe to the CG when they're having those briefings, hey, well, why are you guys not doing so good? You know, yes, this is why. So that's probably the lowest hanging fruit that's out there. The other thing is that when you do physical exam, I always recommend that primary care and inpatient stuff use the 95 rules, because the 95 rules are based on organ systems and body areas, okay? It's a lot easier than having to know all of these bulleted elements. If you're trying to get the comprehensive exam under the 97 rules, it's actually 6 pages of information that you have to know to understand all 57 elements you need to pick from. You don't need 57, but to be able to pick which ones under each category, you'd have to understand it. So I'd say you have to open a book. Now, the other area that is the low-hanging fruit is the data on the inpatient side. So let's pretend do you do any inpatient, sir?
No, I don't.
Okay, all right. We're going to pretend that you do.
Okay.
Real fast. All right. So if I'm the resident and I'm working with this good doctor here and he's rounding with me, and then when we're done with the note, he's over there and he's going to drop in his attestation. We reviewed all the stuff, everything there, but his attestation basically says, I reviewed the resident's note, I agree with the note as written, and blah, blah, and that's it. Well, guess what? This entire category gets thrown away, okay? The attending is the one who is responsible for saying that he or she reviewed the labs, reviewed the orders. If you looked at the imaging yourself, which I know like in internal medicine, you're going to go over the chest x-ray, you might look at the CT. If you look at it yourself, you need to say that in your note because it's worth more points. And especially if this is a hospital admit or an inpatient consultation, you want this credit because that's going to raise you up in your medical decision making. But it's the attending's documentation of that that matters when you look at the rules, okay? Now for risk, come on in, sir. For risk, you have here, what are the issues? Is it a new problem with uncertain prognosis? Is it an acute systemic illness? Is it something chronic that's progressing, that's severe? Are we doing medical management? Are we needing to do surgery? Those sort of things. This is where you look at the risk. You look at, hey, what are we doing? What are the testings that we may need to do? Risk is one of the categories, okay? Now, in the new rules, risk is still there. It's just this table is a little bit more succinct, okay? So, for time, for people who used to code for time and like to go click that little box in Alta and try to get, the time-based things that kind of bump things up, that box does nothing for us now, guys. It doesn't, because all the time rules changed. It's no longer face-to-face counseling and coordinating care. It's actually everything you do for that patient on the day of service, okay? So, when we talk about some of the time stuff, some bean counter came up with this deal that they think that we're going to save 2.11 minutes. So if we're seeing 20 patients a day, we'd save 180 hours per year. Well, if that's 20 patients a day, 2 minutes, let's just round, that's like an extra 40 minutes a day, right? So that could be that on the command side of things, wow, I'm getting pushed as a hospital director to increase my access to care. If my providers are doing a great job of this, I could probably get 2 extra things. That's 40 minutes. I get 2 extra 20-minute visits, right? I'm just kidding. I know that's not what's going to happen, but I'm just telling you how that ball bounces sometimes, right? But when we say, hey, how am I saving that time? Well, now I'm saving that time because I only have to do a clinically relevant exam. So this young lady works in GI. So if I came in to see you, what would be, for a GI issue, what would be a clinically relevant exam in that regard? The GI stuff, right? Do you need to be listening to the heart and lungs or checking what's my range of motion and things like that? No. It's not relevant to what the problem was that I came to see you for that day. If you're in a Warrior Clinic and I came in to see you for a knee issue, do you need to listen to my heart and lungs that day? What's the medical necessity? Probably nothing, right? So you could focus on just that. So imagine that you can write the note and instead of saying, oh man, I've got to hit all these extra bullets or areas, no. You get to do the exam on the knee in the low extremity and that's it. So yes, we're going to save a lot of time. You also don't need a whole bunch of review of systems. Review of systems doesn't count for coding anymore on the outpatient side, okay? So as a urologist, I'm not asking about their heart and lungs and other stuff if I see that they're otherwise healthy. I'm talking about systemic and GU. I still do a review of systems even though I don't have to have it because I want to get good documentation and know what's going on with my patient. But again, it's what you think as the clinician is what matters. Now you can document on time or the medical decision making. But again, like I said, time is the typical time. It's what you're doing that day. That's why the day of service is so important to put on. Okay, somebody asked the question the other day about, well, we get 3 days of close encounter. Well, that's a military rule. That ain't the real world rule, okay? So I try to have all my encounters closed by a certain day, that day. If I can't, where I work, they're actually, if you don't have your notes closed within a certain amount of time, you're actually penalized monetarily, okay? That's my world, right? So yes, I try to make sure my notes are done as fast as possible because I want it coded, I want it off the docket going forward, okay? Now, here, we just talked about this, the nature of what you do, and again, here, this is what we got to break. We've got to break that habit that Alta has conditioned us for years, since it came out, of clicking more to get more, okay? Just doesn't matter there. Now, this is actually a fun one here. At the top, your support staff can actually document stuff off of a portal, off of a patient questionnaire. Your support staff can actually document a vast majority of your HPI, and you get to count it, okay? So if that nurse is going in and they're doing stuff and they, basically have the stuff, you come in as the physician or the provider and say, hey, so I see that you have this, this, and this, anything else? Perfect. Well, part of that documentation is already done. That saved us time, right? So here's one that is very, very, it's tricky, but it also is very, very critical for understanding what we're doing with the new rules. A problem is managed or addressed when it is evaluated or treated at the encounter, okay? So let's say the good doctor here sees me, knows that the GI doctor has been seeing me for my ulcerative colitis. He's not messing with it, but he writes the ulcerative colitis and managed by GI on the thing, and then the other diagnosis is chronic lower back pain and knee sprain, okay? So there's 3 different diagnoses, okay? So if these other 2 diagnoses are stable, and that one there, hey, it's managed by GI, if you say that that one's managed by GI, he can't count that diagnosis as one of his diagnoses for what's the level of his credit, because he's not doing anything for it. Do you understand? Okay? So the thing is that if that's the case and you're not doing it, don't try to add that up, especially if maybe there were only 2 diagnoses today on the encounter, the ulcerative colitis and the lower back pain. The only credit you could claim is for the lower back pain because that's what you're addressing and evaluating, okay? So just be aware of that. That's a big difference in the thing. Now, referral without evaluation. Now, that evaluation can be in the history, the exam, or diagnostic studies. So, let's say, case in point, microscopic hematuria. You noticed on a previous year analysis, patient had 5 to 10 red blood cells per high-powered field. Nothing else was mentioned in the note. It was just put on there, microscopic hematuria, refer to urology. That diagnosis cannot be included in your medical decision making because you didn't document any evaluation of that problem other than it was there, and you didn't order anything for the workup of that problem. That's what the new rules state, okay? Now, if you said, hey, I know, according to best practice guideline, that's an intermediate risk microscopic hematuria, I'm going to go ahead and order that renal ultrasound, and I'm sending that over to urology. Yes, undiagnosed new problem, level 4 problem, you're starting the workup, you got the data, referral, that could be a 99214, okay? So the thing is that it actually behooves us to initiate that evaluation because One, when it gets to the specialist, half of that stuff is already done. We've expedited the patient's care. On the primary care side, we got the maximum credit that we could, and on the specialist side, that person is going to get his credit or her credit when they review the other stuff, and then they'll have to go ahead and make the decision for what's next for the patient. So it's a win-win if we do it the right way. The key is to qualify the work, you got to do the work, all right? And that's something new. Now, number of problems, data, and risk. So let's talk about what are the revisions. Now, they've added some new things, they've taken away some new things. Now, they redefined a lot of these problems and got rid of some of these ambiguous terms. Now, when we look at minor self-limited problem, we expect it to run a course, get better with or without treatment. Now, for a stable problem, okay, if you notice, if a patient is not at their treatment goal, so let's say you were seeing me, sir, and I had hypertension, which had been controlled on, say, amlodipine, but you come back, you see me, and you're like, Dave, man, what have you been eating? You've gained 15 pounds, your blood pressure is a little high today, and you say, hey, you know what, you're not at the goal. I need you at 130, but you're at like 160. So then you decide to add, let's say, lisinopril, right? Renal function is good, you're going to add lisinopril. So you've got a problem that even though you're treating me, I'm not at the goal. Well, then that would qualify for a chronic progressive illness that's not at goal, persistent, not responsive to treatment. These are all descriptive terms that I want you to put in the note so you get that credit. Now, the medical management that you did, that's a level 4 problem. Drug management, 99214. Done, okay? So it's important if you describe what's going on. That's why the assessment and plan is the most important thing that we write. Now, undiagnosed new problem, uncertain prognosis, acute illness with systemic symptoms. Now, just because it has systemic symptoms doesn't mean it requires hospitalization, okay? Pyelonephritis can be treated as an outpatient sometimes, okay? There are certain criteria, but you can. So the thing is that's this, because when you get to this category here, this is something that's exacerbating but does not require hospitalization. But this is something that does require hospitalization. These last two codes here, or excuse me, not codes, but criteria, are the high-level criteria. If you have something that poses a threat to life or bodily function, easiest one is AKI. Somebody comes in with an AKI. Before the creatinine was 1, now it's 7. Something's going on. That patient may need to get admitted to the hospital, evaluation, everything, okay? So if that's the thing and you're making that decision, you're going to get a higher level of care. The key is to describe it. You must describe it. Because understand, the diagnosis is simply that, the diagnosis. It is not your assessment. The assessment is what's going on with that diagnosis, okay? Your orders are the execution of your plan. You still must write your plan out, especially under these new rules, because that's what counts. It's your thought process. We need to know so that, again, when I have her note and I see it, I know exactly what's going on with the patient, okay? Now, here's the grid, and everything centers around this grid. Old days, you had a front and back, lots of little words and everything else and stuff. This is all that matters now, is this page. I will tell you, as a caveat, if you go to the AMA website, there is a free CME that you can do for these new coding guidelines. It's actually very informative, and you can get a copy of this grid, okay? If you print this grid, make sure you pick fit to size. If not, it's going to print out in 4 pages, okay? Because it's supposed to be really, really big, right? So let's look at these, and we're going to break it down in just a second. But you can see you've got 2 out of the 3 categories. So 1, 2, 3. So am I hanging my eggs in this basket and this basket, or am I doing this one and this one, or this one and this one? Okay? That's where it matters. Okay? Because let's say there's a low complexity problem, a chronic stable illness, maybe independent historian, which an independent historian is maybe you see the patient in clinic and they had a TBI They have some cognitive stuff, so you've got the family member there, and the family member is the one who's really telling you the story. They're the independent historian. So if you only have one chronic illness or two or more self-limited problems, and then the independent historian, guess what? 3, done. 99213, good to go, all right? Now, independent historian for the moderate and the high is actually now included in the category 1. So if that independent historian is one of those checks, and then you ordered something, you reviewed something, then boom, you've got your three things there in that category, okay? But you got to say, history was provided by a family member, history was provided by a friend, battle buddy, whatever, okay? We need that in the note. Now, with data, it gets tricky. We just talked about this, and when we look at the test, each unique test, each imaging, laboratory, psychometric, anything, not separately reported, meaning that if I ordered the urinalysis in my clinic, the 81002, and I billed that CPT code, I cannot count that information as one of my data points, okay? Also, if I order the test, you get it when the patient comes back and you discuss the results, you can't double dip. The data credit is given the order and review on that day, okay? So even though you're looking over here, the credit was given here, but that's all right, because like you saw, I showed you on that grid, you don't need that data category every time. Your other two categories of medical decision making will sometimes, and most times, carry your weight, right? So here, independent interpretation. Now, sir, you may look at your x-rays. You may look at the imaging, okay, yourself. If you do, give your own interpretation in the note, because if you saw, that's its own category under data. Now, let's go over here. Let's say if you order the x-ray and then you read the report, that's your order and your review. But if you look at it yourself and give me your interpretation, that's separate from this. And you can get that credit, okay? Now, let's say you're seeing somebody in the patient or in clinic, and they have UC, and then all of a sudden you've noticed, man, the patient's complaining of recurrent UTIs. And you got the imaging and you think, holy cow, I've got an enterovesical fistula. And I think that's why they're getting the UTIs, right? So you pick up the phone and you call me. Hey, Dr. Stanley, yeah, so I got this patient, they've been having these recurrent UTIs. We've been following for UC, and I got the imaging, and it looks like he's got a fistula. I got contrast tracking into the bladder. What can we do? Okay, let's do this, this, and this. You write in your note that, hey, you spoke to Dr. Stanley today about this. This was the plan. He's going to see the patient, blah, blah, blah. Boom. Qualify right there. That's its own category, okay? It's got to be somebody who's not your specialty or subspecialty. So let's say like it was a general surgeon. A general surgeon can't just go to another plain Jane general surgeon. But if they went to the surgical oncologist, yes, that's a different subspecialty, okay? So if you needed that help, yes, you could. Now, the kicker is like, what if you do something in clinic? If you have the capabilities to do an x-ray in clinic, and you do your interpretation of that image in clinic, you're billing the technical and the professional component. So that interpretation cannot count as this category because you're billing it with that code. Does that make sense? All right, so breaking down the chart, as we just talked about, and I gave those examples, here, perfect. If you notice, there's nothing really in this category to do stuff. So you may have an acute uncomplicated illness or injury, say like otitis media or UTI or something like that, and really wasn't a lot of data, but you're going to give a medicine, right? Well, if the medicine's in the category 4, but these other two things would be 3. So if you had 3, and a 4, you're going to get a 3, okay? If it was a 4, 3, and a 4, then it'd be a 4, because it's 2 of those categories. That's the key. 2 of the 3 categories give you the final level, right? The most important thing with the independent interpretation is you documenting your interpretation. And again, you documenting who you spoke to, okay? If you're using that third category, right? if you're saying, hey, the minor surgery with identified risk factors, major elective surgery without factors. Now, look at this one. Social determinants of health. What if you see a patient in a Warrior Clinic and you realize, oh, they're living at home with their family, but maybe, they don't have the best home life. He comes in disheveled all the time. Maybe there's a wound there that you're trying to treat, and you've got wound care involved, and you realize, man, it is always festering. It is always bad because it's not being taken care of. If that's the case, you can document that, because if that affects your treatment plan, that could up the ante on your medical decision making. So those are things that are important. There's something new that we didn't have last time. Okay? So again, being here. Also, too, medical decision making related to the need to forego further testing, treatment, or hospitalization. If the patient is telling you, hey, I don't want to do that, right? If they're electing not to, that also impacts your medical decision making. The same way prescription drug management is a little different. Historically, it was always because you ordered a new med, but it's not always that you order a new med anymore. It's, did you discontinue a med and why? Did you adjust the med dosing or frequency? That's management. Or why did you elect to continue the meds? Because let's say I'm on 3 blood pressure medicines and I'm right at goal, and you document a note, say, look, last time patient was here, we increased or we upped his blood pressure treatment regimen by adding lisinopril. He's already on Norvasc and metoprolol. Currently going to keep this regimen because we finally got him at goal. You're electing to continue that regimen from a medical decision standpoint of, I got him where I need him to be. This is where we're going forward. That's management, okay? Because you have to, I'm doing it because of this. If you don't describe that, you're not getting that, okay? Now, the high-risk stuff, not so hard here if you really have something that's severe and, hey, you got to go to the hospital, drug therapy with monitoring for toxicity, or even changing to somebody to a DNR, de-escalating care. Hey, we're going to start, it's time to move to hospice, something like that. Those sort of things increase that level. This section is a lot harder to get the 5 because now it's 2, so you'd have to get this one and this one, or this one and this one, or vice versa. You've got to do more on the data side for the 5 than you do on any other category. So a little bit tougher, but again, if the patient has something severe and you're putting him in the hospital, then go for it, all right? The key thing I will tell you is that if Warrior Clinic, would you be the admitting physician? No. You call medicine and say, hey, we're doing, all right, so here's the cool thing. People who are watching, close your ears. Now, so the deal is that you finish your note because they can only bill that E&M for those issues one time that day. You did all this work. You got your 99215. Because as soon as they write that H&P and they admit them, if your note's not done, and that note is, that's the note that's going to get credit. And you just threw away your work. Don't do that. All right? So, time stuff. Now, look at this slide. So, everything on here is time. Independent review, all those things. Look, if I'm independently reviewing something, then why do I want to count time? Because I've got that category, right? If I'm having an independent, so I may not need time. But all of these things included in time. The problem with time now is that all the time's increased, okay? So here, these two, they went up. For the follow-up visits, this used to be 15 minutes, this used to be 25. It's higher now, okay? So for time, it's going to be harder to get your 99214, harder to get your 213. So if a 213 is super easy with a chronic stable illness, minimal data, why are you using time for a 3? That doesn't make sense, okay? It's too easy with the other rules. Now, all of these things count in time, okay? I personally only use time when I'm counseling patients for cancer stuff. This is the only time I use time. Or sometimes I do it with dietary modification related to stone formation, okay? Because they're coming in and we're just going over the results, they lit the link, talking about the diet, here's the things, here's what we got. This is the phrase that I use myself, okay? I bill through Blue Cross Blue Shield of South Carolina, Georgia, Aetna, United Healthcare, Medicare. I've never been rejected with that phrase, okay? The thing is, if you're going to code for time, you've got to have, hey, what did I do? That's the key, okay? You don't have to say, I spent 5 minutes with this, 10 minutes with this, 10 minutes with this. That doesn't matter. It's just got to be in there that this is what I did, okay? So ultimately, when we look at this, hopefully this will save you time. Hopefully the new rules, you can peel back all that extra clicking, all those review systems, all the other junk that doesn't really impact what you're doing. But we were conditioned to do it because 25, 28 years ago, that was the rules. You know, that's what they thought was the right thing. Okay, but sometimes if you print out an SF600, it ends up being 8 pages. And what really matters is maybe 2 paragraphs, all right? And that's painful. We all know that's the truth. So the thing is decrease unnecessary stuff, all right? It's not needed in the medical record. But we still want to write a note that, again, you'd feel comfortable if that was the note on your family member, okay? Is it good? Would somebody else be able to pick that up and know exactly what's going on with the patient and take the care and run with it, okay? Again, you have it here, medical decision making or time. I strongly encourage only use time when it is absolutely needed, okay? Don't try to do time, because what's going to happen, some people go, oh, I spent all this time before and after and this and this. Look, if it takes you 15 minutes to write a note, something wrong, okay? But I also, and I've addressed this with the command people, you guys need Dragon. If you don't have dictation stuff, you're getting compared to the private sector, and I'm going to tell you, private sector got Dragon. I have yet to meet a person who can type faster than they can talk. So yes, you want to have those things to save your time and stuff so that you can get this and dictate. And again, you could dictate something so quickly and be done with your note and moving on. I don't want you to bring work home. Let these new rules help you so that when you're done with work at that time, at the end of the day, you're going home to your family, you're not worried about work. Because again, you have a life too, right? Any questions? Any questions from the online people? So again, strongly recommend trying out the AMA website for the CME. It's easy, it's free. Sprinkle a little free on it, make it better. And stuff. Get the grid. It's awesome. And that's all it is. It's 1 page. It's very, very simplified, okay? Again, the trickiest part is understanding that the data, when you order something, that you get the order and the review that day. You can't count it. If I order a PSA and I'm seeing the guy in 6 months and he gets that PSA a few days before the visit, that when I ordered it over here is when I got the credit for it. I don't get the credit for the order and review this time. Now, I'm following that patient. I'm going to order a PSA for 6 more months. So, oh, look, I got that credit right there because I'm ordering it again. But again, you can't double dip it when you have that. The only time you can actually get the stuff for what you've ordered for is on the imaging if you do the independent review, your interpretation. Yes, sir?
I actually do have a question. It's about the prolonged coding.
Ah, okay.
And I know that Captain Grove.
Yep. I have that. I'm going to send that to her. Yes, sir.
Okay, so I probably don't really need to waste your time or anybody else, but just you had that nice little blurb that you had on there about, how you do code for time, because a lot of mine are coding for time.
Correct. Yep.
Because complicated patients spend anywhere from an hour to 90 minutes with them, sometimes longer. And so what is the breakdown of when you get that extended time and what kind of documentation?
So I'm trying to see if I. So here, right there, if it's an established patient, you've got to go over 55 to start using the prolonged service code, okay? And typically, I don't want to misquote, but typically it's like once you get into the prolonged service code, depending on if it's a 15-minute increment or a 30-minute increment, and I'd have to look again because there's different ones for different things. You've got to go into that more before you can get it. You can't do like 5 minutes into it and try to get it because they'll be like, no, not going to happen, right? For the new patient, you got to go over 75 just to tap into the prolonged code, right? So a little bit tougher, that you're doing that. But again, if you said 90 minutes, then yes, 90 minutes for a follow-up, you're going to be into that for the other 30 minutes. Now, if you were at 35 minutes, it's usually going to round down to 30 minutes, if that's the thing. I can't remember just off the top of my head if it was 15 or 30-minute increments, but I have the stuff. I will email it to Dr. Grody.
On Alta, it's 30 for those prolonged. It's 30 minutes.
Well, remember, I don't know if Alta has been corrected yet for that, okay? Now, the thing is, even if it's not corrected, and I don't know if they will, somebody said they might, but if it's not, you'll know, I give information, what it is, and if you went over it, and if you documented in your note, hey, here was the time, total time, then you'd have your 215 and then your other thing, and yes, the coders are going to get it and go, he said there was the time. Even though Alta's going to dupe you here because they may not fix it. So don't get confused. Okay?
And then there have been times when I've done extensive review of records and talking with patients, with other providers, case managers, where I've spent literally 4 hours on one patient, and maybe 2.5 hours of it is after the talk. So when I go to code, the prolonged with the patient. So I get a 99215, then I go prolonged after, with the patient, then prolonged after. There's only 3 choices I can get, so then I don't get the extra, 30-minute increments. So I lose, so there's like an hour of my time.
Well, so with the new stuff, right? I understand. So remember, for the new stuff, it's everything you do on that date of service, okay? You're going to tap into another set of non-face-to-face codes, which is actually very difficult to get if you're doing this on other days other than the date of service, okay? So I would definitely speak with your coder about that, because there's some specific non-face-to-face codes. But I'm going to tell you, I know in the private sector, those things get shot down like, the ducks, right? The duck in Louisiana, they're going down. You're not getting any credit. They're not going to give it to you and stuff. I think here you can, but you've got to describe, again, why it was medically necessary and stuff. That's the key. The biggest thing that I've seen the PASBA auditors and stuff, DSHA auditors, shoot it down is going to be why. They want to know the why. Why was that necessary? And sometimes we fail to do, we can explain the what and the how, but the why wasn't there. And that hurts us. Well, thank you so much for your time. I hope you enjoyed it.